This is a scenario that we have all seen at one point or another in our medical careers. So we have an elderly gentleman who is a hypertensive coming with some kind of musculoskeletal pain and he is having a little bit of high blood pressure in the ED. So very often somebody will come and tell you that the BP is kind of high and whether you want to do something about it. And unfortunately, this scenario, despite being extremely common, is very commonly mismanaged in the emergency department all over the country. And I'll tell you why. So this reminds me of this book, which is called Overdiagnosed, and I'll recommend that every physician who is practicing medicine right now read this book. It will give you a completely different perspective about the things that we do every single day. And the number one chapter in this book is about hypertension. So, how does hypertension, which is a condition that is frankly underdiagnosed and undertreated in large number of people in this country, also be overdiagnosed and overtreated in a different group of patients? So the reason why is that when you are in medical college, that you are taught about hypertensive and how bad it is and all the side effects that it can cause, but we not really taught about this particular scenario, even though it's very common. And we are also not taught about how quickly we are supposed to control hypertension, and we're also not taught about the onset of action of a lot of these antihypertensives. So what you need to understand here, first of all, is that blood pressure is not constant for an individual all of the time. It is always going to vary depending on the, things like pain, external stimuli, environmental factors, behavioral factors, etc. All of these things will have some sort of an influence over your blood pressure values. And you can see here that fairly innocuous sounding activities can produce seemingly significant changes in your blood pressure. That is why often it is recommended to actually measure the blood pressure after about a 15-minute period of rest. So this is one of my favorite studies. It shows that young, healthy people who are doing weightlifting, their BP used to shoot up to as high as 480 over 350. 480 over 350. And people piss their pants over a BP of 160 over 100, remember. So keep this in mind that depending on your scenario, BP of normal people will go up and it will go down. And any patient who is alive will you will see this phenomenon. The guidelines from the American Heart Association and multiple other guidelines as well clearly states that in patients without any symptoms, regardless of what the BP reading might be, you are not supposed to do anything about it acutely. So why is that? The term hypertensive urgency that you and I and most people have been taught in medical school is actually a wrong term, and probably it is something that actually doesn't exist. And the term urgency has led people to believe that these patients need urgent treatment, which is absolutely not true. And it has been shown in multiple observational studies that urgent treatment of this hypertensive urgency actually leads to worse outcomes. It can lead to more myocardial injury, more cases of AKI. I'll give you an example. This is a real case which was posted by IM Crate on Twitter. So a patient came with some musculoskeletal pain, an elderly patient. He actually had a high BP on arrival, 220 over 140-ish. And the treating clinicians decided that even though the patient's lab values were absolutely normal, he was having no organ failure, to actually reduce the patient's BP by giving four different oral antihypertensives as well as IV labetalol. And guess what happened? 12 hours later, the patient's BP dropped to 70 over 50, and then the patient needed IV fluids and later noradrenaline to actually normalize the patient's BP. And look at the graph here. This happened 12 hours after the patient was actually initially treated. This is something that you should keep in mind. If you are over treating these patients, the side effects that will happen to the patient will happen much later on. It will happen after your shift finishes. So you will not actually see the patients experiencing the adverse effects of overshoot hypotension in your shift. So unless you're actually following up these patients, you will not actually realize that you are harming these patients. And this exact same patient actually had a bump in creatinine that actually had not normalized with treatment. So again, this was a patient who had an iatrogenic hypotension and AKI due to overtreatment of the patient's hypertension. So that is why ASAP has clearly defined that patient with asymptomatic hypertension do not need referral to the ED, do not need a reduction in their acute reduction in their blood pressure, and do not need hospitalization. You may consider changing or increasing their antihypertensive depending on the particular clinical scenario. And again, patients who are coming with acute pain, treat the patient's pain. Don't try to treat the patient's blood pressure. You treat the patient's pain, the BP will automatically come back down to normal. So what is an actual hypertensive emergency? The patient will not be walking, talking, smiling kind of patient. Patient will have acute onset vision changes, altered sensorium, turn of the breath, acute chest pain, etc. So the only caveat here is that patients who are having acute renal failure might be having very subtle symptoms. So that is something that you should actually be on the lookout for. But in general, patients who are having an hypertensive emergency will look very, very sick. So in all of the other patients, what are the things that you actually need to do if they're having asymptomatic hypertension? So what you should do is to make the patient chill out for a little bit. So make the patient relax for about 20 to 30 minutes, recheck the patient's blood pressure, and in most of the patients, that will be enough to actually reduce a patient's BP by a little bit. So it has been proven in certain observational studies that patient simply being given 30 minutes of rest will actually reduce their blood pressure by a significant amount. So it will reduce it to below that 180 by 110 threshold that is usually used as a cutoff for the urgency definition. So in the one particular study, so that around 30 two more 1 in 3 patients actually had a significant reduction in BP by simply giving the patient rest, and this was seen to be equivalent to the giving the patients a telmisartan. So once again, amlodipine is not a solution to hypertension emergency. It is not a solution to hypertension urgency, and stat doses of amlodipine has no role in the emergency department, despite what you might think or you might have seen. This is actually the truth. Why? Because amlodipine takes around 8 hours to actually start acting, and for it to actually have the peak effect, it will take a few days. So it has, frankly, no role in any emergency department. It has no role in the emergency treatment of blood pressure. And if you are giving amlodipine and seeing an immediate reduction in BP within about 30 minutes, what you are actually seeing is not the magical effect of amlodipine. It is actually the magical effect of rest. So don't fool yourself into thinking that you're doing something when actually nothing is actually happening. And again, if you're looking for short-term control of blood pressure for some reason, there are much more appropriate options available, which are mentioned here. And again, in actual hypertensive emergencies, different conditions will have different drugs of choices. So everything depends on context. You will not treat a stroke the same way as you treat an MI when it comes to blood pressure management. So everything is in context. And again, neither amlodipine or IV furosemide are going to be the wonder drugs for any kind of hypertension. So I would like to finish here by once again restating that acute reduction of blood pressure is rarely indicated and never indicated in the patient with asymptomatic hypertension. Simply giving the patient some rest for some time will cause significant reduction in BP in a lot of patients. And amlodipine and furosemide are fewer choices for BP control in the mental department for most patients. And you always have to be careful about overshoot hypertension leading to iatrogenic heart pain, especially in your elderly patients. I hope you have found this video useful.